My name's Braden Koenig. I'm a psych mental health nurse practitioner at the University of Pittsburgh. I coordinate our psych mental health nurse practitioner program, and then clinically, I work at a private practice and in our addiction psychiatry clinic at the VA Pittsburgh healthcare system, where I'm the program director for a psych NP residency program. I care for people primarily with opioid use disorder. So, a lot of my patients with substance use disorders are veterans with a history of opioid use disorder, and many of them I have been seeing for many years. And so, I have seen this beautiful trajectory with a lot of my patients where at one point they're struggling with an active opioid use disorder or OUD. I often see them initially when they're in the hospital and then have, transition them to our outpatient clinic. And with treatment, especially evidence-based and patient-centered treatment, people do get better and can go on to live really meaningful, fulfilling lives. Part of that treatment and what the evidence suggests is best, and what I have found in my personal experience really enhances the care people receive, is the use of harm reduction or patient-centered interventions. So we have some tangible harm reduction interventions: naloxone for opioid overdose prevention, syringe service programs, drug testing strips, and I leverage most of those in my practice. But when we really think about harm reduction, it's a way of being with our patients and really a paradigm where we're meeting people where they're at, very much in line with motivational interviewing. And so I personally have seen the success of that. And it's something that I think really needs to be a foundational skill for all nurses, particularly psych mental health nurses who often care for people with substance use problems. Healthcare providers recognize the importance of harm reduction, but then find it difficult to translate that into their clinical practice. So I have heard people say, and again, this is supported by research, that they express concern about liability, right? So they'll say, well, if I provide somebody with drug testing strips, is that encouraging them to continue to use? Or what if I provide them with these harm reduction services rather than counseling them to stop using and then they overdose, right? There's this liability piece that I think people get really hung up on, and then it makes it hard to translate this into care. The other thing I see is where people think that they are using this harm reduction method, and they might be using parts of it, but they're still following that authoritarian approach where patients are told, if you're still using, you're non-adherent and you're discharged from our clinic, right? And we know that really increases the risk of overdose death. So I think there's a disconnect between the harm reduction literature, which is really robust. It's supported by SAMHSA. There's more and more research surrounding it, but as with many things, there's been a delay to kind of widespread implementation in practice settings. State by states, in a lot of states, some of these interventions, specifically syringe service programs and drug testing strips, are still punitive or legalized, right? They're still considered drug paraphernalia in some states. So I think in getting these resources out to people who need them, psych mental health nurses really need to be advocates for looking at state legislation, looking at the barriers to what really are cost-effective, low risk, and evidence-based interventions. On the other hand, is sort of what I mentioned in the idea that using a harm reduction approach really requires us to leverage that radical empathy and to meet people where they're at, even if their behavior and their choices and their lifestyle don't necessarily align with what we want for them. It's recognizing that when a patient sets a goal, even if it might not be what goal I would set for them, that really increases the likelihood that they're going to achieve that goal. Challenging ourselves as psych mental health nurses to be cognizant. I think most of us try to come into a clinical encounter with a non-judgmental approach, but sometimes we do carry judgment and implicit biases that can not only impair the therapeutic relationship, but lead to negative outcomes for our patients. So being mindful of that and really leveraging the idea that people are going to make choices that they feel are appropriate at that time. And for somebody, if that choice is they're not ready to seek treatment for an OUD, I'm going to respect that. But what can we do to keep them alive so that they can seek treatment and recovery when they're ready? I really kind of water it down or drill it down to the idea that people can't get better if they've died of an overdose. So empowering people to use in a way that's safe for them is a cornerstone of treatment for substance use disorders.